Good morning.
Maybe give a couple.
Yeah. Good morning.
Go ahead. Sorry. Yeah.
Yeah. Good morning and good afternoon and good night for some of you who are up in the middle of the night on the other end of the planet. And we're very happy to have you today for this webinar, fantastic webinar that was put together by the Giving Back Committee of the SSAT. I'm Nick Vote. I'm the chairman of the Board of Trustees of SSAT, and it's a pleasure to have this webinar from the Giving Back Committee and Dr. Snyder, the chair, put together a great program with Dr. Hassan, Dr. Gaskill, Dr. Kate, and there'll be Dr. Cooper and also Dr. Balakrishnan there. I want to remind you that the SSAT is 200% committed to global outreach. We have global chapters in Latin America, in Europe, and in Asia. And the society is a society for all, with memberships of all categories, active members, candidate members, and medical students can apply. The membership benefits are incredible. You have access to job, online access to job. You have access to travel grants and awards. And best of all, there is the podcast series called Soundbites. So please join the SSAT if you're not a member today. And if you are a member, you will tremendously enjoy the speakers today. As I said, the SSAT is committed to the global outreach, and we have a special program. We meet, in fact, once a month with a global outreach working group, and we committed to expand the SSAT to all parts of the world. The next chapter is going to be in Kurdistan, so we have chapters all around the world. We hope the countries around the world will join. We are the premier academic digestive surgery society, and we want to remain committed to education. So please join us, and I will let Dr. Hassan now introduce the speakers. Dr. Hassan is professor of surgery at the University of Iowa. He's a colorectal surgeon and has been very committed to global outreach. And as a foreign medical graduate, just like me, you know, it sounds like something very special we have to do. We are on a mission. Thank you.
Nick, thank you very much for those kind words, and welcome to all the speakers and all the attendees who are, I can see the numbers picking up in the background. So thanks again for this webinar from the Giving Back Committee on cancer surgery in low and middle income countries. We have a diverse panel of speakers, and we'll lead off. We'll do all the talks in one go, and then at the end, we'll have a discussion and take questions from the audience. Please put your questions in the chat, which we'll monitor also, or speak up when the time comes. Again, thanks again for joining us, and I echo everything that Dr. Vote has said about SSAT. I started off very early, and this is the only one of the few societies in which I've really enjoyed and got to know people who I would otherwise not have known if I just stuck with colorectal surgery. So thanks again. So the first speaker is Dr. Hoover Cooper, who is from Honduras and is an oncologic surgeon there. I will let him take the floor, and he can introduce a bit more about himself, and then he can go into his talk about the barriers to screening in low-income countries. Thanks again, Hoover, for joining us.
Well, thank you very much. So we're going to start with this fourth webinar, very interesting. So as Dr. Hassan said, I'm from Honduras. I'm a surgical oncologist and hepatobiliary surgeon, and I work in a hospital in the capital city of Honduras, that is Tegucigalpa. So the topic that we're going to have today is very interesting, and it's very challenging for countries like lower income countries and middle income countries. We got a large challenge in screening and prevention of cancer. So that is the talk about. So if I share a screen over here. Okay. So we're ready, no?
Perfect.
Okay. So the talk from today is very short, but it's very important because doctors or physicians from lower and middle income countries, we know that we have big challenges in screening of cancer. So, second here. So regarding recent reports of the global burden of cancer, estimates that there are like 18.1 million new cases of cancer and 9.6 million of deaths in the 2018 and worldwide, no? So as the burden of cancer of the burden of communicable disease and cardiovascular disease continues, the incidence of cancer as well is rising up in lower and middle income countries. So regardless of the geographic area, the social determinants of health seems to play a crucial role in cancer control and its outcomes across the globe. Even higher income nations, like factors related to social determinant of health, play a vital role in obtaining cancer screenings, including social demographic factors, health literacy, cultural beliefs, and the lack of beliefs in preventive health. So socioeconomic status and lack of access to healthcare. Also patients' attitudes like beliefs, like patient, including fear to cancer, and inadequate number of facilities, equipment with cancer screening tools all prevent timely screening. Unfortunately, limited allocations of resources to healthcare and lack of implementation of government policies ultimately affect prevention and disease burden. Although the incidence of cancer and screening is in lower and middle income countries, the cause of cancer is limiting its affordability. Therefore, a focus on cancer prevention, early detection, and use of novel and cost-effective methods of screening are invaluable in lowering cancer incidence as their related financial burden of country economy. So if we start talking about tobacco use, we know that the cigarette smoking increased the risk of at least 12 cancer. We know that includes acute myeloid leukemia, bladder cancer, colon, rectum, esophageal, kidney, larynx cancer, liver, lung, so pancreas, stomach, and cervix. Currently, it's very interesting because more than 1 billion people in the world use tobacco products. And if nothing is done to help them to quit and to prevent young people from starting, more than half of these people will succumb to premature deaths from tobacco-related disease. Tobacco control has a well-developed package of evidence-based interventions that are proven to work. These interventions are enshrined internationally in what we call the FCT, that is the Framework Convention of Tobacco Control. That was the world's first public health treaty under the auspices of the World Health Organization. However, in most of the lower and middle income countries, the main provisions of the FCTC are barely implemented. So this leaves plenty of room for improvement. So the encouraging news that for public health, for the FCT, they divide all these things in 5. So the most effective provision is the increase in taxes. This is in taxes of tobacco products. This mechanism is very simple. When the government raises the taxes, the companies raise the price to maintain the profits, and higher prices lead to lower consumption. So typically a 10% increase in tobacco prices lead to a 4 to 8% decrease in consumption. The second effective provision is graphic warning levels on tobacco packing. Research consistently shows that educating users, particularly young people, through package promotes quitting and reduce initiation. The third one, banning of tobacco industry marketing. Is the third one is very interesting of this one. And the fourth is the provision of smoke-free laws that prohibit smoking in public and workplace. We know that exposure to secondhand smoke causes substantial mortality and morbidity annually. So smoke-free laws not only protect non-smokers, especially children, but they normalize smoking. And it's well established that smokers are more likely to quit and young are less likely to start when smoking is rarely observed in public. An important fifth intervention is the use of mass media campaigns to inform the public, where areas incorporating learnings about the dangers of tobacco use in school curricula is important and useful. Targeted mass media campaigns are provided to be better investment value. Young people are particularly responsive to social media sources. We know that, no? From which they typically get the most of their information. Regarding cervical cancer, we know that it's an important public health problem in lower and middle income countries, where screening programs do not exist or are ineffective and high risk of HIV infection exists. It is well established that persistent infection with one of the 13 high-risk types of virus of human papillomavirus may lead to the development of high-grade cervical precancer lesions, such as cervical intraepithelial neoplasia grade 2 and 3, or even adenocarcinoma in situ. So if we let them untreated or undetected, may lead to develop the invasive cancer. So there is evidence that cervical precancer lesions can prevent by HPV vaccination, and cervical cancer can be prevented with early detection and treatment of precancer lesions. We know that cervical cancer is the fourth most common cancer in women, ranking after breast cancer, colorectal, and lung cancer. So regarding the screening, cervical cancer can be prevented. And we know that if we detect the cervical precancer lesions with screening with cytology or even with visual inspection, we know that 3 to 5, we know that this will lower the cases. The fact that the HPV testing is more sensitive, accurate, and reproducible in detecting high-grade lesions is more effective, but in lower and middle income countries, we don't have this. We only can use cytology, the conventional cytology. The problem with the vaccines in our countries is, for example, in Honduras, we started using it like 6 or 7 years ago. So we haven't seen yet what are the benefits for the vaccine. We're going to see this probably in 10 to 15 years, but we have a high number of patients with invasive cervical cancer, and it make it a big health problem in the country because most of the women, they are around 40, 30 years old, and they're single women, and when they die, they leave kids younger age, so those kids practically, they're alone, and this create a big problem. Kids start going in this country, for example, when don't have parents, they start going in gangs, and they become a social problem as well. So at the end, it will be better and easier when we have a vaccine and prevent this disease, no? Regarding breast cancer, is the most common cancer in women, and even in both in developed and undeveloped countries. The majority of lower and middle income countries, we don't have screening guidelines in place. So high risk screening and chemoprevention options seems unfeasible for us. For example, mammography is an option, but a lot of people don't have access to health service. In most of the countries, even the hospital, they don't have a mammographies. So it's very difficult to create a program without having the tools in low and middle income countries. So even the self breast examination, it can help, but we know that we need mammography, ultrasounds to start detect cases in early stage of the disease. Once the patient can palpate the tumor, probably it will be in stage 2 or 3. So to reach the cure of this patient will be very difficult, because even most of the lower and middle income countries, they don't have even chemotherapy or radiation therapy. In the case of our country, we only have one cancer center that is public for all the country, no? So imagine people have to travel 8, 9, 10 hours to this center. It's impossible. So most of them, they don't reach the hospital. And it's very interesting because in private service, we have whatever you imagine, whatever you need, you have it in private, but 90% of the population is poor and they can't afford it. So we have like a very challenging treat and prevent breast cancer. And even if we use the clinical breast examination, it is very difficult. If we pass to head and neck cancer, it's a lot of cases, and it contributes, you see on the slide, 4.9, 4.7 of the global cancer incidence in the world. And 76% of the head and neck cancer and 84% of this cancer occurs in lower and middle income countries. As the other cancers, we know that more than 70% we find in lower income countries of all the cancer. So the thing is that this cancer can be largely preventable, and it costs a lot of money to make prevention of this cancer, probably $16.9 billion per year. And this is not in lower income country. This number is in one study that China, it costs $69 billion in the year to prevent this. And the thing is that surgery in our countries and lower and middle income countries remain the treatment of choice of these cancers. And the other thing is that because we don't have radiation therapy, we don't have chemotherapy, and it's very interesting because in most of the lower and middle income countries, surgeons will treat the disease, but we have lack of head and neck surgeons. No, we don't have them in most of the countries, so the treatment is not as well. Liver cancer, it contributes the 83% of the global incidence of liver cancer and 82% of mortality from liver cancer. This is in 2018. So we know that poor survival rates make liver cancer the 7th most common cause of cancer mortality worldwide. This is after lung, breast, prostate, colon, non-melanoma skin cancer, and stomach cancer. Hepatitis B vaccination, universal safely precaution for prevention, transmission of blood-borne infection, blood products safety, supply of sterile needles and syringes to injectable drugs user, and safe sex practice have been shown to reduce the transmission of hepatitis B and C. Not all the countries have the vaccine. Most of the lower income countries, vaccination from hepatitis B is only given to people that are health workers or people that are in contact with some kind of jobs. So it's not for all the population. Also, with the screening, sonography or ultrasound is the standard surveillance test that is recommended for the American Association of the Study of the Liver Disease. You can add up this alpha-fetoprotein. The problem is that people don't have access to health service. So to make a screening for this population is very difficult in lower and middle income countries. Regarding esophagus, stomach, and colorectal cancer, in lower and middle income countries, they all together contribute to 75% of the global annual incidence and mortality from esophageal, stomach, and colorectal cancer. So the thing is that some studies say that the contrast radiography and upper endoscopy have been used for screening stomach cancer, and not all patients they're going to have access for endoscopy, even to make the screening in all the population is very, very difficult. So probably even to make a screening help patients, imagine the amount of studies that they had to make done in one country that they are in lower and middle income in countries. They don't have the equipment, enough equipment in the hospitals or in the clinics to treat all the population. So make a screening for gastric cancer is very, very difficult in lower and middle income countries. So it's very controversial as well. As we know that esophageal cancer is related to tobacco, alcohol, malnutrition, HPV. They are very, very risk factors for squamous cell carcinoma. So if we screen people with Barrett's esophagus, is debated, because we don't have if we don't prevent the use of tobacco, if we don't prevent the use of alcohol, it will be very difficult to start searching all the population to find Barrett's esophagus in low and middle income countries. Regarding colon cancer, the best option is the fecal occult blood test. And for colorectal cancer, it reduces the mortality, is very cheap in relation to the colonoscopy. And it has to be probably used in lower and middle income countries. However, most of these countries, they don't have the program to do it. They don't have the guidelines that there has to be like every patient when they reach each age or when they are having some symptoms to send from the FOBT. It's not on the guidelines for most of the health programs in lower and middle income countries. Even like most of the countries in low and middle income country, we don't have guidelines. We just work individual as if a physician makes decision not related to a guideline or to a program or a protocol. We don't have them because in lower and middle income countries, we have lack of research, we have lack of database. So it's very difficult in this scenario to make a screening of cancer. So in conclusion, the incidence of mortality of cancer are increasing in lower and middle income countries. However, more than 70% of the common occurring cancers in these countries have evidence-based prevention, screening, and early detection intervention. So lower and middle income countries, we should invest in low-cost cancer awareness, prevention, screening, and early detection programs. I don't know if you have any questions.
All right, thank you, Hubert, for that excellent presentation. Do you have any more slides, or was this your last slide?
The last one.
Okay, all right, thank you very much again. And hopefully at the end of the webinar, we can kind of have all the panelists talk amongst each other and take calls or in the chat box. So we'll circle back to that towards the end. So the next speakers it's a double team. It's Professor Kate, who's the professor of surgery at the Jawaharlal Institute of Postgraduate Education, and a surgical trainee, Dr. Balakrishnan, who is training to be a surgical oncologist at the Cancer Institute. Again, welcome to both of you, and you can briefly tell a bit about yourselves also, and then you can get right into your talk. Thanks again, and appreciate you coming.
Yeah. Thank you, Dr. Hassan, and I'd like to thank the SSAT, Professor Vapi, and the chair of this Giving Back Committee, Dr. Rebecca Snyder, and my co-speakers. Very happy to be here and sharing some of my experience on this topic. I hope my slides are visible.
Perfect, perfect.
So through this talk, we'd like to share something we have just now heard Dr. Cooper on the barriers. We'd like to share our experience on resource constraints, what we see here in India and LMICs, and the disease awareness challenges that we see and the solutions. So I'll be speaking upon the resource constraints and initial aspect, disease awareness, and other aspects. My student and my mentee and Dr. Gurushankari Balakrishnan will be speaking. I'm actually a professor and of general and GI surgery, and this is at Pondicherry, south of India, and presently also holding the charge of Dean Academic, and also incidentally I'm the inaugural president for the SSAT for India, as Professor Vaughty has mentioned that all across the globe now we have SSAT chapters. Thank you very much once again. Now, why this webinar? What is the importance of LMICs and the cancer? That we have seen that earlier we used to have increased burden of these communicable diseases, malnutrition, maternal and child health. That was the focus of low and middle income countries. But now there is a part control on this aspect. And what is usually seen is that there is an increase in non-communicable diseases such as diabetes, hypertension, and also cancer. So because of this shift now, there are resource constraints. Already they were there. This has got accentuated, and the disease and the risk factors awareness, which is still poor. The MDT approach, again, it is not very much accepted and not very much widely available. And of course, when it comes to something like research or translation research, again, it is very, very limited in low and middle income countries. So we'll be discussing our talk together on the challenges and solutions of the resource constraints, the problem of disease awareness among the patients, the risk factors, what are the difficulties because of MDT not very clearly followed across the stream, and and how do we evolve together towards betterment of humanity. Now, if you see this, this is the projected cancer burden in India. If you see 2021, 26.7 million. And 2025, you can see it is almost increased by 20%. It's significantly affecting their dailies, and there is a sub-regional variation. More than 40% of total cancer burden, what we see here, now the lung cancer is the commonest, followed by breast cancer, then the GI cancers of esophagus and stomach. And if you come across GI cancers, North India, we have gallbladder cancer, which is extremely common as compared to the upper GI tract cancers like carcinoma esophagus, carcinoma stomach, which is quite common down south of India. Now, this is a Indian Council of Medical Research study. You can see there 2004, and now you can see 2001. So lung cancer, which was quite low in 2004, it has ascended right up to the top, and it is the topmost cancer right now in India. Of course, we had some decline of cervical cancer, and most of the other cancers have remained stabilized with minor changes. So what we usually propose is that there should be targeted policies and programs. Because of this regional distribution of cancer and the needs, it should be targeting the diseases which are more prevalent in a country like India or LMICs than across the stream because of the constraints of the resources. Why there is a paradigm shift of cancer as such in LMICs? Earlier, it was not so common. So aging population, because of good birth control, now we have people going up to 60, 70 quite comfortably. Most of the people, life expectancy has increased. Then some degree, substantial control, we can say, of communicable diseases, better health facilities, and of course, better governmental facilities. But in spite of this, if you see across the spectrum of LMICs, the people estimated cancer death, what we see there, that so many 70% of the deaths occurs in LMIC. What's the reason for that? Even though the overall incidence is low in LMICs due to younger population, the problem is that most of these patients are not having access to facilities. Due to that, there is a disadvantage to them, and by the time they present, they already have an advanced stage, and because of the advanced stage, the mortality is high in these people. So if you compare high income group versus low and middle income countries, high income countries versus LMICs, if you take what is mentioned in gray here, you can see there the HIC better risk factor control is there. If you see comparison here, tobacco, alcohol, as it was mentioned earlier also, and you can see this Indian Council of Medical Research study, such a high prevalence of second largest tobacco consuming nation in the world. Cancer registry, again, very good in HICs. You can see the cancer registry. It's abysmal, 1%, 4%, 4%, Africa, Asia, South and Central America. Then if you see the research, as I mentioned earlier, continued and progressive research is there in HICs and LMICs. It is still in the nascent stage. And there are tertiary care institutes which conduct very good research, but that is not widely available. Most of the people, the infrastructure in LMICs that you have primarily the primary health center, the community center, which actually deal with the patients, and practically there is literally no research at that level. Funds are very limited, financial burden, all these things are very good in HIC for control. And if you take the LMICs, cancer diagnosis, not only financially challenging, it is emotionally challenging for the patients. And because of the emotional involvement, what happens is once they are diagnosed with cancer, many times they will not come to the hospital further for further checkups and just manage on their own. And unless and until, like if it is a GI tract cancer, they have obstruction or something, they have come to us with an advanced disease when practically nothing can be done for that. And you can see here the costs. For a standard treatment of early stage HER2 positive breast cancer, it would cost 10 years of an average annual wages in India. So you can see so much of discrepancy is there as far as the income is concerned because of that, these difficulties and constraints. So when it comes to resource constraints, infrastructure, as I mentioned, you have primary health center, community health center, district hospitals. Till that point, the infrastructure is not very adequate. So because of that, it is a big hindrance for the management of cancer patients. Then you have the manpower division. You can see doctor-patient ratio, nurse-patient ratio low. Appropriate technology, digitalization of data is not there. Allied medical sciences, technicians for medical oncology, radiation oncology, or operation theaters itself, we might not have adequate manpower. Research, as I mentioned earlier, it is limited, and collaboration at national and international level, again, are very limited. And the pharmaceutical industry, if we have a very good support from that, good quality medicines are produced by that, definitely that becomes a very plus point in LMICs. So how do we approach it? What are the solutions for this? Solutions are that quality and care equal to all. Whether the person is poor or rich, he should have very good, proper healthcare facility available to him or her. Telemedicine services, because sometimes travel becomes difficult, and nowadays with the ubiquitous availability of cell phones and all, definitely that is improvising. Genetic screening, of course, is a very difficult task. And vaccinations, even though they're available, two problems are there. One is the cost, and more important than the cost is that the hesitancy of vaccinations, which was seen, we have seen recently for COVID, how it happened that one of the problems, major problems of the spread of the disease was the hesitancy in taking the vaccination. Same thing happens here. People don't believe that vaccinations can prevent cancer. So that sort of thought process is there. So that leads to problems. Then state and government schemes have to improvise the insurances. Insurance should take care of the travel for the patients, because travel, food, stay, all these things are hindrance because the patient again cannot afford. And all these things will reduce the out-of-pocket expenses for the patients. And of course, we have to have good quality and population-based research, because if you have to have the use of drugs which are even manufactured in other countries, in HICs, whether those drugs work at the local level, regional level, all that thing has to be tested, tried, and researched at the local level. That is why it is extremely necessary. And the research has to begin at a training level and should be widely available. As I said, even up to district hospitals is very rarely done. So those are the hospitals where you have a good number of patients, and you have a good number of research facilities. So in those circumstances, definitely it can be used. Then you have if you have staff to room ratio, appointment timings, all these things can be adjusted they are usually adjusted by overbooking and shifting appointments. And because of cancellations, we cannot afford to have a cancellation and let the OT go free. We cannot have the cancellation and let the endoscopy room go free. Sometimes what we do is the endoscopy is also shared. The one side we start the endoscopy, do the main part, and then we go to the other room and have alternate modalities. So a person who's an endoscopy specialist available can carry out more than what is actually should be done at his level, so that we can actually use the manpower very optimally. All these things actually will lead to improving the process in healthcare system with better coordination and continuity of care, which will definitely help and improvise the cancer care management in patients who are residing in LMICs. Now I invite my student mentee, Dr. Guru Shankari Balakrishnan, to continue her talk on the awareness, disease awareness, and the role of multimodality therapy. Dr. Guru Shankari, please.
Yes, sir. Are my slides visible and am I audible?
Yes.
Yes. So very good evening to all. First of all, I would like to thank SSAT as well as the SSAT Giving Back Committee, Professor Bauti, Dr. Imran Hassan and Dr. Rebecca Snyder for giving such a wonderful opportunity to present. And I would also like to thank the association manager as well as my co-presenters and my mentor, Dr. Vikram Kate. So I am a surgical oncology resident training at Cancer Institute Adayar in Chennai. So I'll be going through the disease awareness part as well as the multidisciplinary team approach. What are the challenges we face as well as what are the solutions that we can, through which we can overcome these challenges. So most of the patients in LMIC present with advanced stage of the disease. The reason behind is that they don't have much awareness about the disease. They don't have awareness on where to seek help and whom to contact as a first contact point. So we need to have more and more health promotions, concentrating more on school students as well as on community-based strategies. And prevention strategies should always focus on primordial and primary prevention. And as earlier speakers have spoken, we need to have more and more screening and early detection of malignancy. And multimedia plays a very important role these days because everyone, even in LMIC, are having an access to phone, and there are very limited information in the phone or sometimes even false information that we get from multimedia. So we need to have a channelized and scientific data also being included in the multimedias. And we need to have national, regional level awareness programs as well. So why it is important to have an early diagnosis? Because there are certain cancers which will benefit because of early diagnosis. For example, breast, colorectal, head and neck, which are the major bulk in LMICs. And we also see pancreatic, prostate, and bladder, which does not have much effect with early diagnosis. So as you see, there are delays at various levels once the patient comes with the symptoms, from the time of symptoms to presentation, then from presentation to diagnosis, and then to diagnosis to treatment. So why there is a delay? So initially, when the patient presents with symptom, the first person they contact is the neighbors. And then the neighbors, everybody will have different opinions. And then they go to a primary healthcare center, which is a first contact point. And we know in all LMICs, most of the primary healthcare centers have not equipped enough or doesn't have the infrastructure to diagnose malignancies. They are well equipped as of now for communicable disease, but not for non-communicable diseases. So once they go to the first contact point, then they get referred. From there, they need undergo the diagnosis. Once the diagnosis is done, then finally go to the appropriate specialist. So all this leads to a delay. So we need to have a comprehensive care in a primary healthcare system itself. We still have like cancer stigma, fear of examination, and difficulty in access to primary healthcare centers and lack of transportations. And we also see most of the specialty centers are in major cities. So these are the barriers. And we also see there are some inaccurate diagnosis that happens because of lack of poor techniques. And also we see a lot of financial and social barriers. People who are well educated tend to go for a second opinion. They go for a second opinion from one person to other, from one oncologist to other oncologist. They all have seek to try get treatment from an alternative medical therapies because they are not satisfied with the modern medicine where we offer surgery, chemotherapy, and more radical therapies. And we also see defaulted in the sense not only from the point of diagnosis, but also even after the completion of treatment, especially when we do a reconstruction and resection in head and neck surgery, we keep him on long-term follow-up. We see that people tend to default and come with a very bad recurrence. So how do we go about having a solution to all these problems? Is that having a national and state level awareness campaigns, trying to reduce the risk factor which can be modified. For example, infection related, alcohol, smoking, all those can be cut down and keep the patient under proper counseling and surveillance. So this all, we need to have better cancer researchers, even in LMIC, supported well by the funding agencies. And also, in case of screening modalities, as spoken earlier, high quality screening may not be feasible, but we need to have an alternative where it can be very easily implemented in a primary healthcare center by a trained person. So moving to multidisciplinary team approach, very few centers in India has oncology dedicated centers, and they are also not supported well enough by other specialty. For example, we have difficulty in treating patients who have diabetes, hypertension, CKD and CAD and has a cancer because we don't have an in-house specialty people. So we need to have more and more multi-specialty support system, even for a low socioeconomic strata, as we give it for a higher socioeconomic strata person. On board of a multidisciplinary team, not only surgical oncologist or medical or radiation oncologist, but we need to include more psycho-oncologists, which is coming up in a very big way, radiologists, nuclear medicine, even nursing staffs, and try to incorporate patient and their caregivers. So what happens in an MDT is you first discuss, then you put forward the treatment plan to the patient. By then patient takes some time, there is a delay in the entire process. Once you include the patient and the caregivers into the system, and you tell them on the day of MDT that this is what we have planned, this is the offers we have, then the process becomes more easier. We also need to include more of preventive oncology people, as well as the palliative and rehabilitation care also should improve. So we need to have healthy debate in an MDT with where all the like surgical and medical oncology, it should together come and then have a patient-tailored approach rather than trying to prove which is superior. So this often happens in an MDT, which should not be considered. And we also need to focus more on risk factor modification. For example, in LMICs, we see patient with head and neck cancer who has a risk factor of smoking continues to smoke even after having multiple excisions or multiple treatment for oral malignancies. And we need to also have a family and genetic counseling. So for example, breast cancer patient who are presenting in a very young age, we need to go back to their family, see their daughters, see their mothers, and then you need to counsel their family. And we need to have better palliative and rehab centers because most of the patients present in stage 4 malignancy, and we don't have anything to offer for them. The immunotherapies, even for lung cancer, the tyrosine kinase inhibitors are very costly drugs which cannot be offered to lower socioeconomic strata person. So we need to have a better medication facilities as well as palliative and rehab centers. Whenever possible, if you are not having a medical oncologist or a radiation oncologist on board, try to do a virtual MDT so that the patient will not be shifted from one center to another center. And we need to give equal space for our allied specialists such as speech and swallow therapists and physiotherapists who help in recovery of the patients. Of course, we need to have a research team who will look into this process because they will pick up areas where we can do the research. So to summarize, we need to focus on giving equal care. It should not matter whether the patient is from a lower socioeconomic strata or a higher socioeconomic strata. We need to have research initiatives because research is the ultimate thing which will lead to addition of data, gives value to your literature, and it will show data to the policy makers telling that you need to focus more on this area. And you need community-based approaches where national and state level initiatives are required. And there are multiple programs and existing strategies available to control cancer. So we need to expand on it. Just like India has done very well in trying to control tuberculosis by putting in a lot of strategies. So similar strategies has to come up for malignancies as well. And we need to expand medical care to unreached areas. We need to involve more and more allied sciences. For example, paramedics, technicians, data analysts, typists. So they will all reduce the burden on the medical healthcare facilities, and also more and more technologies. We need more funding, not only for healthcare, pharmaceuticals, but also for research. We also need quality research and data from LMICs. And we need to enhance more on multidisciplinary and multimodality treatment facilities. So to end this, I would like to say this. This is a theme of the World Cancer Day, February 4, 2023 this year. Close the care gap, and the call to unite our voices and take action. Create a future without cancer. The time to act is now. We may not be able to create in LMIC a place where there is no cancer, but at least we can improvise and cut down on morbidity and mortality by early diagnosis and treatment.
Thanks again, Dr. Kate and Dr. Balakrishnan, for that excellent talk. Just moving along, our next speaker is Dr. Cameron Gaskell, who's a hepatobiliary surgeon and has a special interest in global surgery. So he will present his perspective from his context. Thanks again, Cameron, for joining in.
Thank you so much. Thank you, Dr. Vote and Dr. Hassan. As said, I'm a surgical oncologist and HPV surgeon at UC Davis. I'm also the director of our Center for Global Surgery. I'd like to thank the SSAT and my fellow panelists for highlighting the very important topic of building global oncology capacity in LMICs. Today, I'm speaking on the importance of collaboration to advance global surgical oncology. I've been working in this academic field for about 10 years and have ongoing projects around Sub-Saharan Africa and Central America. One of the most common questions I receive from surgeons wishing to get involved in global surgery programs from both high and low LMICs is how to build stronger collaborations. Collaborative work is well studied. A lot of information comes from the business world, but it's easily applied to medicine and global health. Several key facets are important in collaborative efforts and good to think about as you build these groups. That said, I'd like to highlight a few things I found to improve the success of global surgery oncology collaborations. Now, the first, and I think the most important, is engaging stakeholders. Global health is a discipline of complex systems. Global surgery, as opposed to infectious disease or other classic global health fields, requires a lot more support and multidisciplinary engagement. Now, cancer surgery is even exponentially more complex. So I use this figure, an example of liver surgery, to illustrate how many people are needed to be engaged early when looking to improve liver cancer treatment capacity. As an example, I was working in Ghana where we realized we had a lot of these parts, but in a country of 30 million, we only had 11 working pathologists, causing a large bottleneck in the system's ability to improve cancer care. Now, there are many moving parts to these complex systems, many of which are dependent on one another, and an easy omission can be made to produce a major downfall. When building these projects, it's important to get everyone in the room, make room at the table for everyone, and listen to everyone's ideas for priorities and build a shared vision. I like the old adage of a rising tide floats all boats. The second thing I focus on in building collaborations is defining a shared goal. As you build these groups, everyone should bring a different strength to the table. Now, this allows a situation where the whole is greater than the sum of parts, but these pieces, or rather people, are interdependent and need to have a good natural fit. This highlights the importance of defining priorities. In general, these should be set by those familiar with the setting and the specific resource constraints. One of the common downfalls I see in global surgery and cancer collaboration is trying to force a fit. You see this a lot when high-income surgeons come in with an idea of a project they want to complete, but it doesn't align with the needs or the priorities of the environment. For example, I do robotic gastrectomies. While I'd love to bring the advantage of that operation to Tanzania, robotic surgery is not the priority at this point. The photo in the lower corner is of an endoscopy suite in Muhimbili National Hospital. An example of shared vision that I'm proud of is in addressing nutrition for cancer patients in Tanzania. We've built a collaboration with multiple projects looking at complications of surgical tube placement, feasibility of outpatient tube feeding, PEG placement training, nurse nutrition education, feeding tube initiatives, and even standardization of local feeding formulas. Now, enteric nutrition is not my premier interest, but it's the priority of my surgical oncology collaborators and allowed us to engage ENT, nursing, GI, and others to build a strong collaboration that we're now expanding towards looking at treatment outcomes, chemotherapy compliance, and national advocacy. The next point I'd like to highlight is building trust and strong friendships. Now, so this is a picture of Adam Jidu. He's a surgeon in Ghana that I spent years working with. And we've built this strong friendship that encourages candor and honesty. Our joking around has produced more new ideas than any focus group ever has. And we've promoted a way of thinking both alike and differently about problems and projects. And these friendships become the core of a collaboration, and building on this, a part of this is finding someone that you trust and complement. But this is only done through showing up and being a dependable partner. Within these collaborations, my primary role now as a high-income surgeon is really to support the local physicians. Along the efforts to decolonize global health, I see my role as a shared leader, bringing my strengths to help collaborative priorities. Now, we see again and again that outside physicians are less effective in leadership and building capacity. We did a study on this actually a few years ago, looking at local physicians serving on mission trips to underserved areas within their own country. We found that there's huge advantages of this over the classic foreign doctor mission, including being more cost effective, improving follow-up and referral lines, building capacity of the remote physicians, and caring for complex patients in these areas. Now, I use this to exemplify that the days of foreign doctors dropping into a location to operate and leave is ending, and the focus should now be on how high-income surgeons can support research, education, and capacity of our LMIC collaborators. You know, the research infrastructure, grant writing skills, and biostatistics that I bring with me on my trips today are more valuable than my hands have ever been. Now, bidirectional collaboration is a term used often in global health, and that describes the mutual benefit of collaboration for both the visiting and local teams. Surgeons from high-income countries have a huge amount to learn from the experts working in the constraints of low-resource settings. And in fact, a lot of funding opportunities are now mandating that they have proven benefits of these projects to both domestic and international patient populations. However, we've kind of gone beyond this now. We've started to develop a way of triangulating collaboration. So using low, middle, and high-income collaborators to trial interventions in multiple locations, each learning from the experiences of others. So one example of this is in gastric cancer screening. So the photo down here is one of my collaborators in Honduras. We're using the UK NICE criteria to triage patients with concern for gastric cancer for urgent endoscopy. We've already applied this in South Africa and found success in a lower resource environment, and now we're using the same project in Honduras. So each of these settings has its own challenges, but by triangulating the collaboration, it's allowed these collaborators to share solutions, provide mutual mentorship, and make improvements to capacity in all settings. There are also collaborations to be built outside the hospital. If you look at the Harvard Business School training on collaboration, they stress the importance of executive support in the success of any project. Similarly, stakeholders outside the medical field, especially the government, should be included. Addressing the government's priorities is often a great opportunity for building collaboration, as well as finding new outside support. So an example I've illustrated here is in Tanzania, where the government made a call in their strategic plan to increase the number of trained surgeons. We collaborated with other like-minded NGOs and institutions to take advantage of this opportunity, built a surgical oncology curriculum aimed at early faculty and residents in Tanzania. So it's wonderful when these priorities line up, as we're able to include the Ministry of Health in our work, and it's opened other opportunities to build education initiatives and support our mission of improving surgical oncology capacity. Outside of clinical programs, there's also been a recent effort to improve research by connecting providers and facilitating collaboration of shared local data. So historically, global surgery has suffered in a lag of outcome data because databases are small and hard to enroll and isolated. These collaborations have allowed a nimble system to assess cancer outcomes quickly and widely implement new interventions with ease. For example, the Global Surge Collaborative now links more than 90 countries with individual institutions, providing consistent real-world, on-the-ground data on treatments delivered in cancer patient outcomes. Now, getting involved in these research collaborations is a really easy way to enter this field and allows you to meet others engaging in similar studies and build additional projects. Finally, collaboration can also be supported through research and training programs. Several organizations are working to help build cancer research capacity and offer great opportunities to build strong collaborations. The Fogarty through the NIH is one. It's been a huge component of global research mentorship. Additionally, programs like Global Cancer Program at UCSF and the African Research Group at MSK, both D43 funded, are helping to support and train LMIC doctors in global cancer surgery research. Research, training, and clinical capacity often go hand in hand and produce new opportunities onto themselves. So in conclusion, building collaboration is essential in global oncology. The friendships made are often the most rewarding part of this work, and inclusion is key. Stakeholder engagement really drives the direction and success of these projects. Global surgical oncology is quickly gaining attention. I encourage everyone here to connect your various colleagues along common goals and interests. Thank you again to the panel. I encourage anyone to contact me via email if you have any questions after the discussion.
Dr. Gaskell, thanks again for that excellent overview, and it's very commendable the amount of work you've done. I've learned so much that I didn't know before, including the fact that you have collaborators in Honduras, and maybe Hoover can touch base with you and see what we can do going forward. Again, thanks to everybody else, Dr. Kate and Dr. Balakrishnan and Dr. Hoover. So we'll open the, we have a few minutes for discussion. We'll see if anything's up in the chat, but I'll lead off with one question. Hoover had mentioned about smoking and as that the government putting taxes on it to decrease that. And then the slide from Dr. Kate's talk about lung cancer being the #1 cause of mortality. And I'm assuming that's due to smoking. So has the government of India or the local agencies done anything to curtail smoking, and what can be done in that context?
Dr. Hassan, yes, Government of India has done something very great on that respect. That it is about, I think, 8 or 10 years back, one of the doctor health ministers, he had put it that any video or any movie or any picture where smoking is shown, immediately 2 things will be shown. That even on the television, it will be shown that smoking is injurious and it can lead to cancer. That is #1. And all the cigarette packets, they have put photographs of patients with the fungating disorders in the face and all, indicating oral cancer. So those are the ideas which government got and they have taken, and that definitely must be one of the detrimental factors working for against smoking. That is what I can think of. Dr. Gurushankari wants to add something, she can add.
Yes, sir. Actually, when I was in my MBBS day, even more younger, I would see people who are smoking in the roads and other things, but now it has come down very much. It's all happened because people are more aware that it can lead to malignancy, and it's been the multimedia has been used very much in this in order to spread the news among people. So people usually tend to watch movies in theater, very common entertainment for the Indian population. So that is where our health minister has used it very efficiently to create the awareness.
Very good, thank you. And Hoover, you had mentioned about cervical cancer and the trying to set up a program for that and how that has helped. What else do you think needs to be done for, not to be selfish, for colorectal cancer? How do you think that, what could that be decreased, and how can screening be improved for that?
Well, yeah, for colorectal cancer, no?
Yeah.
Okay, for colorectal cancer, yes, the how do you say, fecal cord blood test, it will help a lot. The only thing that, as I said in the talk, that we don't have guidelines or even we don't have like protocols. So every physician, they can work however they want. So probably if we work with, for example, medical college of the country, so they can send and say that the importance of having this test done in this kind of patients, it will work, because that is very cheap, and I know that all the hospitals in the country they can have it done there.
Thanks again, everybody, for your time and participation. I'll let Dr. Bote have the last few words to wind up. And thanks again for everybody who, there are participants that I can't see their names, but they're online. Thank you very much for joining. I hope this was interesting. And thank you to all the panelists for contributing. Dr. Bote.
Yeah, thank you to all the participants. And I've been involved myself with outreach in Nicaragua for many years. And there is a place for everyone to collaborate, from the people like Dr. Gaskill, who will design healthcare in collaboration with the different countries and with the leaders in different countries, to the day-to-day practice. So I think we should not forget that. And also, we as surgeons are very interested in a day-to-day practice. So there's nothing like, role model who go on site and still get their hands on the work that's being done there, because you are all remarkable in what you're doing, Dr. Cooper, also, with what you've done in Honduras. Please note that starting with small, in terms of SSAT, we have small research grants, and we want to educate our junior member, our candidate member, our medical students, and we have small research grants for all the new chapters. So please join the SSAT. And thank you so much for all of you. I think it's remarkable what you are trying to do and we are trying to do. I think we'll have to maybe reach a more global network with Zoom and include more people next time. I think we've talked about multidisciplinary conferences. I think they should be reaching more globally and not at the level of a single hospital. And they should be, in fact, interacting multidisciplinary conferences. There's an example that's been done by Dr. Tay in the Philippines, where she has 600 people participating in multidisciplinary conference on a weekly basis. So I think there's room with new technology to reach out to everyone. And I won't be longer because I can see Dr. Hassan is in charge of this Zoom. We don't want to go over time and bore you. Okay, we'll see you soon. Thank you for being part of SSAT.
Yeah.
Bye-bye.
Good night. All right.
Right.
Bye-bye.